Hi, everybody. This is Jeanne E. Poole. I'm the editor-in-chief of the HRO2 Journal. This is the February 2026 podcast. The title of the first paper in this issue is Does Hemolysis Matter After Pulsed Field Ablation for Atrial Fibrillation? Insights from the Best Ablate Registry. This is by Dr. Shamlu and colleagues. The key findings are first, that pulsed field ablation for atrial fibrillation was associated with an increase in hemolytic parameters without significant short-term renal impact or occurrence of clinically significant hemolysis. Second, acute kidney injury was rare, 3.6%, and mild, indicating that hemolysis after PFA does not usually translate into short-term renal dysfunction. And third, the total number of PFA applications independently predicted hemolysis intensity, demonstrating a dose-dependent relationship between lesion burden and hemolytic biomarker change. The title of the next paper is Awake and Ablated, First Experience with a Balloon and Basket PFA System Without Propofol by first author Roland Tiltz and colleagues. The first key finding is that pulmonary vein isolation using balloon and basket pulsed field ablation was performed safely and feasibly under multimodal conscious sedation with fentanyl, midazolam, metamizole, and lidocaine, without the need for escalation to deep sedation. Second, patients reported high comfort and satisfaction levels, as well as a high likelihood of recommending the procedure based on structured and time-resolved follow-up assessments. This approach may enhance procedural autonomy, improve resource efficiency, and support patient-centered care in routine electrophysiology practice. Next up is a paper titled Pulmonary Vein Isolation and Beyond Feasibility and Acute Outcomes of the Lattice Tip Dual Energy Catheter for Complex Ablations by Dr. Ilaria Mai and colleagues. First key finding is this was a single-center prospective study including 102 patients undergoing initial or repeat catheter ablation using a novel lattice tip catheter capable of delivering both pulsed field and radiofrequency energy. Second, the dual energy lattice tip catheter was feasible for complex left and right atrial ablations, targeting multiple atrial substrates. Third, pulmonary vein isolation and linear lesions were achieved efficiently with 100% acute procedural success. Next up, acute periprocedural safety events occurred in 3% of patients. And finally, early remapping data demonstrated durable pulmonary vein isolation and persistent linear ablation sets, especially for mitral isthmus lines and posterior wall isolation. The title of the next paper is First Multi-Center Japanese Registry on Tissue Proximity-Guided Pulsed Field Ablation, Procedural Safety and Midterm Outcomes by Dr. Sawada and colleagues. First key finding is that this is the first multi-center real-world study to evaluate the procedural performance, safety, and short to midterm outcomes of tissue proximity indication, TPI, guided pulsed field ablation using a variable loop circular catheter. Second, TPI guidance enabled efficient first-pass pulmonary vein isolation with a low rate of acute gaps, while failure predictors such as high body mass index, absence of pre-procedural mapping, and procedures performed during the early learning phase. Third, no clinical strokes or transient ischemic attacks were observed, and vascular complications were minimal, highlighting the safety of standardized PFA workflows across multiple centers. Fourth, careful procedural preparation, including pre-mapping and appropriate anesthesia, is important to maximize first-pass PVI success, particularly during the learning phase. And finally, structured operator training and adherence to standardized safety protocols can effectively mitigate early failure risks and reduce the likelihood of neurovascular complications. The title of the next paper is Left Atrial Anterior Scar in Persistent Atrial Fibrillation, Results with Pulmonary Vein Isolation and Linear Ablation, including Posterior Mitral Line. This paper is authored by first author Maureen Arnaud and colleagues. The first key finding is that anterior left atrial scar is associated with a specific patient phenotype. Second, spontaneous left atrial anterior scarring is associated with a significantly lower arrhythmia-free survival at 12 months after the first atrial fibrillation ablation procedure than patients without scar, 65.7% versus 82.9%, p-value 0.0038. And finally, the presence of left atrial anterior scar is an independent predictor of arrhythmia recurrence, even after adjusting for confounders, hazard ratio 1.29, with a p-value of 0.015. The title of the next paper is Early Recurrence of Atrial Arrhythmia Following Catheter Ablation of Atrial Tachycardia Consecutive to Ablation of Atrial Fibrillation, using the updated blanking period by Dr. Raphael Spittler and colleagues. First key finding is early recurrence within the first 56 days after atrial tachycardia ablation performed for post-atrial fibrillation ablation was independently associated with late recurrence of atrial arrhythmia in both univariable and multivariable analyses. Second, patients with early recurrence experienced a higher number of arrhythmia episodes beyond 56 days. And third, early recurrence demonstrated moderate predictive value for late arrhythmia recurrence, positive predictive value of 69%, whereas the absence of early recurrence did not reliably exclude future arrhythmia recurrence, negative predictive value of 47%. The title of the next paper is Using Subcutaneous Nerve Stimulation to Control Atrial Fibrillation by Dr. Pengsheng Chen and colleagues. First key finding is that 2 weeks of subcutaneous nerve stimulation did not reduce the atrial fibrillation burden or control the ventricular rate in patients with paroxysmal atrial fibrillation. Second, there's a lower increase in percent AF burden over time in the stimulation group than in the sham group. Third, in the week after stimulation, the ventricular rate during AF in the stimulation group was faster than in the sham group. The title of the next paper is Electrocardiographic Effects of HBI 3000. Sulcardine sulfate, a new drug for termination of atrial fibrillation by Dr. J. Mason and colleagues. First key finding is that HBI 3000 is a new intravenous antiarrhythmic drug for the treatment of recent onset atrial fibrillation. Second, HBI 3000 blocks multiple cardiac ion channels, including peak sodium current, late sodium current, L-type calcium current, and the rapid component of the delayed rectifier potassium channel, IKR. Third, excessive QT prolongation by HBI 3000, a block of IKR, is prevented by its inhibition of delayed sodium channel and I calcium, which shortens the J2T peak interval, reducing the overall extent of QT prolongation. Fourth, HBI 3000 was well tolerated up to a dose of 600 milligrams IV over 30 minutes. The next paper is Comparative Cardiac Electrophysiologic Analysis between Sinus Rhythm and Atrial Fibrillation, the Correlation of Left Atrial Low Voltage Substrate of Sex and Rhythm by Dr. Guifeng Zhao and colleagues. First key finding is, in a sex-balanced cohort, the authors established sinus rhythm low-voltage area cutoffs from atrial fibrillation maps and quantified sex-specific voltage differences. Second, the following 3 findings emerged. 1. Global mean left atrial bipolar voltage was markedly higher in sinus rhythm than AF. 2. Women had lower voltages than men at most sites in either rhythm. And 3. AF thresholds predicted sinus rhythm of less than 0.5 millivolts with acceptable accuracy. The title of the next paper is Atrial Fibrillation Detection in Endurance Athletes versus Non-Athletes, Positive Predictive Value, and Burden Estimation using Implantable Cardiac Monitors. The first author is Dr. Jeanne E and colleagues. First key finding is that the positive predictive value of implantable cardiac monitor detected atrial fibrillation episodes was similar in endurance athletes and non-athletes. Second, longer AF episode duration was strongly associated with higher positive predictive value, increasing from 0.42 for episodes less than 6 minutes to 0.89 for episodes greater than 60 minutes. Third, automated AF burden estimates moderately correlated with validated AF burden, improving substantially when episodes less than 6 minutes were excluded. Finally, these findings indicate that ICMs provide reasonable AF detection performance in both athletic and non-athletic populations, but excluding short-duration AF episodes enhances the accuracy of automated AF burden estimation and may improve clinical interpretation. The next paper, the title is Inappropriate Shocks from Subcutaneous and Transvenous Implantable Cardioverter Defibrillators, Reports from the FDA MAUDE database by Dr. Robert Hauser and colleagues. The first finding is that in the general population, subcutaneous implantable cardioverter defibrillator is associated with substantially more inappropriate shocks than single-chamber transvenous ICDs. Second, oversensing physiological and non-physiological signals is the most common cause of SICD inappropriate shocks, whereas misinterpretation of atrial rhythms is the most common cause of transvenous inappropriate shocks. Third, an adequate chronic R wave is vital for preventing subcutaneous ICD undersensing and the consequent deactivation of the SMART pass filter, which reduces oversensing. Inappropriate shocks may be arrhythmogenic. Inappropriate shocks induced more SICD patients into ventricular tachycardia or ventricular fibrillation than transvenous ICDs. And finally, real-world studies are needed to determine the root causes and risks of subcutaneous ICD inappropriate shocks. This paper is followed by an editorial for the paper by Dr. Christopher Monkhouse, Pierre Lambiesi, and Dr. Saeed Ahsan. The title of the editorial is When Signals Diverge and What MAUDE Can and Cannot Tell Us About Subcutaneous Implantable Defibrillator Inappropriate Shocks. The next paper's title is Factors Associated with Complexity During Transvenous Lead Extraction and Confirmation of a Very Low Risk Subset by Dr. Emma Francis and colleagues. First key finding is that the number of implantable cardioverter defibrillator leads, combined lead age, number of leads, presence of abandoned leads, patient age and implantation, patient age of transvenous lead extraction, and time since implantation of the oldest lead were all independent predictors of complexity. Second, there was a low frequency of major intraoperative complications, 1.1%. And finally, there was a very low likelihood of needing complex tools or a major intraoperative complication for recently placed years, defined as less than 2 years for pacemaker and less than 1 year for ICD leads. The next paper's title is Risk Stratification in Transvenous Lead Extraction, Current Models and Clinical Applications by Dr. Alphonsus Liu and colleagues. First key finding is that although overall transvenous lead extraction procedural major complication and mortality rates are low, individual risk is highly variable. Second, post-procedural mortality rates remain substantial despite high acute procedural success rates and non-infectious indication. Third, risk stratification tools provide a framework to improve resource allocation, reduce surgical response time, inform discussion with patients, and guide the intensity and duration of follow-up after lead extraction. Third, the electoral registry outcome score risk model takes into account lead and non-lead parameters and has been externally validated using the large electoral registry and can effectively predict post-procedural mortality, major complications, and use of powered sheets. And then finally, patients with risk factors for higher post-lead extraction mortality, such as infectious indication, renal impairment, advanced age, symptomatic heart failure, device upgrade indication, and acute procedural complications should be monitored closely with repeat clinical assessments and blood tests. This paper is followed by an editorial with the title Transvenous Lead Extraction and the Shape of Risk by Dr. Venkata and colleagues. The title of the next paper is Echocardiographic Assessment After Left Bundle Branch Area Pacing, Impact on the Tricuspid Valve Apparatus, Clinical Value and Perspectives by Dr. Taina Bar and colleagues. The first key finding is left bundle branch area pacing leads more frequently across the tricuspid valve at an anterior site, whereas right ventricular apical pacing leads tended to cross in a more posteral septal position. Second, the early incidence of new-onset lead-induced tricuspid regurgitation or worsening of pre-existing tricuspid regurgitation appeared to be low, but represented 10.2% of patients with leaflet or commissural impingement identified. Third, an immediate beneficial effect of left bundle branch area pacing on indexed left ventricular stroke volume, post-implantation global longitudinal strain, and time to peak strain dispersion was evidenced. And fourth, early systematic transthoracic echocardiography to detect complications is essential after device implantation, particularly for left bundle branch area pacing. The next paper's title is Utilization and Implementation of Remote Monitoring of Cardiac Implantable Electronic Devices in Australia and New Zealand, Adoption Workload and Integration Challenges by Dr. Jeanne and colleagues. The first key finding is that from 2019 to 2023, cardiac implantable electronic device implants in Australia increased by 16.5%, rising from 32,145 to 37,437 procedures. Second, during the same period, percentage of CIEDs issued with remote monitoring transmitters increased from 59.9% in 2019 to 84.7% of 2023. Third, remote monitoring use in the public sector increased from 25.9% to 65%. However, the use rate remained lower compared with the private sector, which increased from 83.1% to 91.6%. On average, CIED clinics dedicate 30.2% of their workload to managing remote monitoring. And finally, CIED patients with remote monitoring have longer intervals between in-person follow-ups than those without remote monitoring, 10.0 versus 7.2 months, p-value less than 0.001. The title of the next paper is Association Between Deceleration Capacity Quantified Vagal Tone and Vasovagal Syncope Patients with Different Responses to Head Up Tilt by Dr. Pakashati Maniti Jeanne and colleagues. The first key finding is that enhanced deceleration capacity quantified vagal tone was differentially associated with head-up tilt test-based vasovagal syncope subtypes. Deceleration capacity's association with cardiac inhibitory mixed and head-up tilt negative vasovagal syncope was stronger than with vasodepressor vasovagal syncope, suggesting that vasodepressor patients with vasovagal syncope exhibited lower deceleration capacity quantified vagal tone than other subtypes. Third, lower deceleration capacity, shorter course, and comorbid hypertension were significantly associated with a vasodepressor response to head-up tilt amongst patients with VVS. And then finally, deceleration capacity showed potential discriminative power for VVS, and deceleration capacity greater than 7.8 milliseconds may serve as a promising approach to VVS classification without reproducing syncopal symptoms. The title of the next paper is A Custom Analysis of R-to-R Interval Properties Reveals Alterations in the Brain-Heart Axis in Experimental Animals with Metabolic Syndrome by Dr. Olivier Mestig and colleagues. First key finding is that sympathal excitation and withdrawal of parasympathetic tone occur in metabolic syndrome, affecting heart rate dynamics. Second, metabolic syndrome constrains the functional range of heart rate and impairs the heart's ability to adapt to low beating frequencies. Third, the sort RR (percentile distribution of RR interval durations) analytical approach provides novel quantitative and graphical representations of heart rate variability distribution that are not captured by traditional metrics. And finally, the SORT-RR framework defines R-to-R interval ranges influenced by pathological conditions or pharmacological interventions, underscoring its potential as an investigative tool for basic cardiovascular research and clinical screening. The title of the next paper is Local Modifications in Tissular Conditions Before PFA Increases Acute Lesion Size by Dr. Gerard Amoros Figueres and colleagues. First key finding is that this study demonstrates that calcium-enhanced electroporation is feasible in the left ventricle of a large animal model and permits the creation of wider and deeper pulsed field ablation lesions than the application of pulsed field ablation alone. Local injection of a calcium chloride-rich solution prior to PFA application increases lesion width and depth by approximately 40% in a large animal in vivo model. Finally, ventricular fibrillation occurred in 48% of calcium-enhanced PFA applications, whereas no VF was observed in control lesions, indicating a substantial arrhythmogenic risk. The title of the next paper is Spatio-Temporal Mapping for Detection of Anatomic Locations of Drivers of Atrial Fibrillation in Swine by Dr. Jeanne E. and colleagues. The first key finding is that atrial fibrillation drivers were successfully identified across all swine using the similarity score framework, with a greater number of drivers detected during pre-pulmonary vein isolation AFib than post-PVI AFib. Second, during pre-PVI AFib drivers were located both within and outside the pulmonary vein regions, demonstrating that AFib activity in this model is not limited to PV sources. 3. After PVI, AFib drivers were found exclusively in non-PV regions, indicating that PVI effectively eliminates PV-based activity, whereas residual AFib drivers persist in other areas of the left atrium. And fourth, AFib drivers transitioned from a mixture of PV and non-PV regions pre-PVI to predominantly the appendage, septal wall, and posterior wall in the post-PVI stage, highlighting the dynamic spatial changes of AFib substrates. Next up is a paper that is titled Artificial Intelligence-Guided Personalization Ablation Improves Freedom from Atrial Arrhythmia in Heart Failure, a sub-analysis of the tailored AF trial by Dr. D.J. Laccaretti and colleagues. The first key finding is that a personalized dispersion-guided ablation targeting regions of spatio-temporal dispersion improves the freedom from atrial fibrillation after a single procedure when compared with anatomical pulmonary vein isolation across all New York Heart Association classes. Second, a tailored ablation strategy is beneficial in terms of freedom from any arrhythmia in patients with advanced heart failure. And third, these findings highlight the importance of implementing individualized ablation strategies in patients with heart failure. The next paper is titled Effective Estrogen and Testosterone in Cardiac Electrophysiology and Atrial Fibrillation by Dr. Ashwin Venkatakrishnan and colleagues. First key finding: receptor heterogeneity drives sex-specific cardiac electrophysiologic changes. Chamber, sex, and development-dependent variability in estrogen and androgen receptor subtypes likely modulate ionic current profiles and underlie sex-specific susceptibility to atrial fibrillation. Second, estrogen and testosterone have opposite electrophysiologic effects. Estrogen prolongs action potential duration by suppressing repolarization potassium currents, IKR and IKS, and reducing calcium transients, while testosterone shortens action potential duration by enhancing repolarizing currents, IKS, IQ1, and ITO, and increasing calcium transient amplitude and SR spark frequency, producing faster repolarization and greater contractility. Next, estrogen is anti-arrhythmic while testosterone is pro-arrhythmic as per laboratory studies. In vitro and animal studies consistently demonstrate that testosterone promotes atrial reentry and delayed after depolarizations, whereas estrogen mitigates these electrophysiologic triggers, theoretically conferring protection against AF initiation. Next, population studies show inconsistent associations between sex hormones and AF incidence. Population studies report conflicting results on association between estrogen and testosterone levels and AF risk in either sex, likely due to inadequate control of confounding factors and reliance on single static hormone measurements. And finally, human-induced pluripotent stem cell-derived atrial cardiomyocytes offer a novel direction for further laboratory research. This is a promising platform to study sex-specific electrophysiologic effects with greater translational relevance with animal ventricular models, although limitations in maturity and hormone receptor expression remain. The title of the next paper is Anatomic Complexities of the Human Right Ventricle: Considerations for Clinical Practice in the Electrophysiology Laboratory by Dr. Renee Brigham and colleagues. First key finding is that right ventricular anatomy is highly variable and can impede catheter manipulation, affecting mapping resolution and the ability to deliver proper ablative and pacing therapies. Second, this review leverages a unique anatomic database of more than 850 human hearts, providing direct visualizations and quantitative assessments that reveal anatomic complexities not discernible with current clinical imaging modalities. And finally, images within this review feature complex right ventricular anatomy, including papillary structures, tuberculations, chordae tendineae, and tricuspid valve anatomy, along with fat deposits in the apex and comparisons of epicardial fat distributions. The title of the next paper is Sexual Health in Patients with an Implantable Cardioverter Defibrillator, a Narrative Review by Dr. Patricia Poole and colleagues. The first key finding is that sexual activity in implantable cardioverter defibrillator recipients imposes mild to moderate cardiovascular demand of approximately 3 to 5 metabolic equivalents and is safe for most patients when guideline-directed therapy is in place. Second, up to one-third of patients avoid sexual activity because of fear of shocks, anxiety, or partner concern, highlighting the need for early reassurance and structured counseling. Third, routine assessment of sexual health using brief, validated questionnaires can normalize discussion, identify unspoken fears, and guide targeted intervention. Fourth, evidence-based interventions, structured exercise, and partner-inclusive counseling consistently reduce fear and avoidance and improve confidence and quality of life. And finally, integrating sexual health education and assessment into routine ICD follow-up bridges the gap between evidence and practice, ensuring person-centered cardiac care. Next up is a paper that is titled Buccal Dantrolene for Rapid Systemic Delivery, a Novel Antiarrhythmic Approach by Dr. Jeanne E. and colleagues. The first key finding is that a novel mucoadhesive water-soluble buccal film formulation of dantrolene was developed to enable systemic absorption while bypassing hepatic first-pass metabolism. Buccal administration of dantrolene in the porcine model resulted in early detectability and a time-dependent increase in serum concentrations. Third, serum concentrations varied with formula pH, with significantly higher levels achieved using more alkaline films. Next, dantrolene was detectable in serum as early as 10 minutes after buccal application. And finally, no local adverse effects such as hyperemia, bleeding, or ulceration were observed in the buccal mucosa. The title of the next paper is Cable Tricuspid Isthmus Ablation with a Focal Dual Energy Catheter, First Commercial Experience by Dr. Mohammed Madali and colleagues. First key finding is that a focal dual energy mapping and ablation catheter, SPEAR-9, enables efficient single catheter workflow for combined atrial fibrillation and cable tricuspid isthmus ablation, eliminating the need for catheter exchanges and supporting streamlined procedural management. Second, CTI ablation performed with radiofrequency alone or in combination with pulsed field ablation demonstrated acute efficacy, achieving 100% bidirectional block with high first-pass success and no procedural complications, including the absence of coronary spasm. And finally, short-term outcomes were favorable with minimal arrhythmia recurrence, supporting the feasibility and safety of this dual energy strategy while underscoring the need for larger studies to confirm long-term durability. The next paper is a research letter, and the title is High Density versus Point-by-Point Mapping in Ventricular Tachycardia Ablation, a Comparative Analysis of Substrate Characterization by Dr. Adrian Petzel and colleagues. The authors conclude that high-density mapping appears more effective in identifying isochronal crowding relevant to VT ablation. For low-voltage scar delineation, high-density and point-by-point mapping strategies were largely equivalent. These findings support using either high-density or point-by-point mapping for a voltage-based ablation approach, whereas multipolar mapping should be preferred for functional strategies targeting local activation. So with that, we wrap up February 2026. As always, I want to thank all of the listeners to this podcast and, of course, all of you that continue to read HRO2 and submit articles. We really appreciate it, and we'll talk to you next month.